Today the topic for discussion is urogenital tuberculosis. This topic I have presented recently in the CMB, so we'll upload here also. So this topic will be covered under the following heading: why this topic, pathogenesis, important renal manifestation, clinical features, diagnosis, and how to manage. See, in India, the incidence of the pulmonary tuberculosis is increasing, as we all know. And because of the chronic malnutrition, poor socioeconomic status among those people, the incidence of extrapulmonary TB, also in those with immunocompromised state, is increasing. And if you take the urogenital system, it is the third most extrapulmonary site. After pleura, lymph node, third is the urogenital tuberculosis. Why this number 20 has been kept? The incidence is up to 20%, 2 to 20% after the pulmonary tuberculosis. It is not hard and fast, but up to 20% of patient might develop. And how many years it will take? The year varies from person, immune status, and nutrition and other parameters. Reports have shown even after 20 years of primary pulmonary event, the patients are developing this situation. So that is why the past history is very important. So this is the image showing the kidney urogenital tract, ureter, bladder, urethra, and the genitalia. Compared to the kidney, involvement of the urotract, that is the draining tract, pelvic calyceal system, ureter, bladder, and the urethra is more common than the direct kidney involvement. Direct kidney involvement compared to the urotract involvement is somewhat rare. So what are all the direct renal manifestations which are possible? It can be formation of ulcer. Ulcer is nothing but the damage to the epithelium or localized formation of abscess, perinephric bed of TB, caseating necrosis, calcification, and in rare condition, chronic interstitial nephritis and the glomerular nephritis. These are all the important direct renal manifestations. So this animation just to show how this TB bacilli reached the kidney. Of course, it reaches the lung by the aerosol route from the lung. How it have came to the kidney? By two ways, probably by the hematogenous spread from the primary complex that is in the lungs and the lymph node. It might be dormant or it might be active. If active, through the hematogenous spread goes to the kidney. From there, capillaries to the tubules to the excretory system. Another important role is the thoracic duct. There is a lymphatic spread from the lymph node. There is a back spread in the thoracic duct and it reaches the kidney. Usually, hematogenous spread, both the kidneys might be involved, whereas in lymphatic spread, which is through the thoracic duct, unilateral involvement is more common. So, from the blood supply, it might reach even the direct renal parenchyma, that is the cortex, cortical abscess, or the cortical granuloma might be there, or it gets filtered and it reaches the tubules. From the tubules, it reaches the loop of Henle. From there, there might be dormancy of this bacilli for a long period, similar to this cat which is lying idle. Similar to that, it might lie down for a long period of time, ranging from years to decades. It might form an abscess or erosions. From there, the presence of bacilli into the draining tract might occur. From there, it reaches the submucosal space, lymphatic site, or it forms granuloma, inflammation, stricture, and obstructive uropathy. So, as I already told in the beginning, chronic malnutrition, immunocompromised state are important, but in the loop of only what are the parameters? An MCQ for the super specialty entrance preparators, the low blood flow, high amount of ammonia, hypertonicity, and the impaired immune response in those areas. Those are all the important parameters which lead to the establishment of these bacilli in the loop of Henle, which forms the abscess. Next, which these kind of abscesses or the bacilli seeding might result in chronic interstitial nephritis, abscesses, these kind of pyramidal, which is papillary necrosis, distortion of the anatomical structure. From there, it reaches the draining tract in the submucosal area. It might establish, or it might from granuloma, inflammation, stricture it can cause. So these are all the manifestation, and this is how it reaches. So this completes the pathogenesis. So in the lower urogenital tract or the upper urogenital tract, inflammation, damage, which result in stricture formation, the common narrowest area might get involved more, which result in the hydronephrosis, hydroureteronephrosis. The urethra might also get damaged, bladder might be involved, which result in various manifestations. On the long standing, as I told, because of the direct renal involvement or because of the recurrent UTI and chronic antibiotic use, the kidney might go for a damage, the EGFR might start falling. So the patient might reach a state of ESRD in the long standing, at least 5 to 10 years. So next comes the important MCQ or the fancy signs that you might get in TB. This corkscrew ureter, time and again it has been asked in 2018, what are the entrants say, either PGI, AIMS, Jifmer, corkscrew ureter, famous question by the examiners. In the contrast imaging, either IVP or CT, the distortion of the ureter is so much it looks like a corkscrew, which is called as corkscrew ureter, and it is typically seen in tuberculosis. And as I told you, stricture and the ureter might be narrowed, which is called as pipe stem sign or the pipe stem ureter. Those are all the two important fancy signs. And one more thing which is related to MCQ is the renal involvement. Based on the amount of destruction or the severity of the damage, it can be staged. Stage 1 is just the TB of the parenchyma, which is non-destructive form. Second one, there is a mild damage, that is a small destructive form, which is also called as TB papillitis. Third is the destructive form, cavernous TB. Fourth is widespread destruction of the kidney. Probably an nephrectomy might be required, which is the stage 4. This is mainly for the solving the MCQs. Higher the severity, higher is the damage. Whenever the delay in the treatment occurs, this kind of severity worsens. Another MCQ, Ultratech cement cup pick I kept because of the caseous necrosis there will be dystrophic calcification where the kidney is called as cement kidney, also called as putty kidney. Again, time and again asked in MCQ in the previous year, probably this time NEET SS or even the NEET PG, you might encounter this question where you will get cement kidney or the putty kidney, which is seen in tuberculosis of the kidney. And bilateral kidney involvement is somewhat rarer than unilateral. Whenever there is a bilateral involvement, high chance the patient might be immunocompromised in the form of anti-malignancy treatment or HIV or any other immunocompromised state, or in the presence of miliary TB, hematogenous spread. In hematogenous spread, bilateral is more common than the unilateral. Another fancy sign, gold hole ureter. The place where the ureter enters the bladder gets damaged and gives the appearance of this directly open up ureter, which is also called as the gold hole ureter. Again, which is seen in gold hole sign, which is seen in tuberculosis. Which investigation? It is not the CT, it is through the cystoscopy. You can see this kind of appearance. The entire bladder might get inflamed, which is pancystitis. The bladder capacity might go down because of the fibrosis. The timbal bladder can occur. And rare manifestations like amyloidosis. Amyloidosis, I hope you know, chronic inflammation causes a condition called amyloidosis, protein folding disease, and rarely, as I told, glomerulonephritis and interstitial nephritis can occur. Vertical transmission can occur, but it's very rare. If in the MCQ if they ask vertical transmission can occur or not, yes, it can occur, but it is very, very rare clinically. And the average period after the pulmonary TB varies from patient to patient, depends on the patient overall health status. Even after 25 years, 30 years can also cases been reported. And epidemiology, male is somewhat more common than female at the ratio of 2:1. So it is the slow insidious process, and there is no specific clinical symptoms with which you can diagnose the urogenital TB. Usually, patient might be having pyuria, that is presence of pus in the urine, or for some other investigation, if they have did the urine examination, there might be presence of microscopic hematuria. Patient usually have increased frequency of micturition, hesitancy, urgency, long-standing fever, all non-specific lower urinary tract symptom. Suppose a patient is having abscess in the kidney, probably a back pain might be a manifestation. Proteinuria, usually less than 1 gram. Very rarely it grows more than it reaches up to 3 gram. And because of the long-standing TB disease or because of the long-standing multiple antibiotics, the patient might reach the stage of ESRD, where all the manifestation of the ESRD can occur in the form of anemia, hypertension, pedal edema, those things can occur. Fever is of course tuberculosis, evening rise of temperature might be there. If it is not active TB or only formed the granuloma, structure was formed, fever might not be there. So when to suspect? Whenever there is a past history of tuberculosis, if the patient presents with the lower urinary tract symptom, recurrent urine culture is showing negative report, that is the time you have to suspect that it could be a urogenital TB. So how to diagnose? 3 important steps. First, there should be a clear history. Ask for the past history, tuberculosis, even after 25 years or 30 years. That's just think it might be possible that patient might be harboring tuberculosis in the urogenital system. 3 ways to confirm it. One is the prove that patient is passing AFB in the urine. Second one is imaging. Third one is the tissue diagnosis. So in the urine examination, you can send the urine for AFB, PCR, or the culture. Probably the entire voided morning urine sample might be required. At least up to 6 samples might be required. You can't rule out the disease by sending one sample. And many a time what I see in the clinical situation is they send the sample similar to other urine culture in the small vial. So that should not be there. You have to ask the patient to submit the entire voided urine have to be sent. Probably centrifuge sample they will take in the lab. At least how to collect the urine for the tuberculosis checking, I will update in another video because it have to be dealt in detail. At least you can remember the entire voided urine have to be submitted. At least 3 to 6 times, 6 days might be required, because yeah, single negative or 2 or 3 reports negative might not rule out this condition. This is regarding the sensitivity. Urine MTB, that is the culture, might take weeks for the reports to come. Specificity approaches 100%. Regarding the PCR, sensitivity and specificity is good, but the data on the reliability of this report in extrapulmonary is not yet clear, or the data is limited. Imaging investigation, CT urography best. Previously, IVP was being used. Nowadays, to catch the structural abdomen, even the minute granulomas and all, better predicted by CT urography, the arterial phase, venous phase, and the excretory phase. You can look at whenever there is any evidence of direct TB related structural damage, start the patient on ATT. And third one is biopsy or FNAC. This is showing there is a presence of TB in the tissue. And how to confirm? How to do it? Either through if the lesion is in the bladder, through the cystoscopy, you can go and take the sample from the granuloma. In the kidney, if there's a proteinuria, if you are suspecting TB related chronic interstitial nephritis, probably a lower biopsy from the lower part of the kidney might be helpful. Apart from that, in the pelvic calyceal system and the ureter, very difficult to take the biopsy. So better to take the initial 2 things, that is to prove the presence of TB in the urine and the imaging one. So as in all the cases, tuberculin skin test or the allergy skin test indicates infection, not any active disease. So whenever clinical suspicion, either one of the following: imaging or presence of urine, TB. Third one, biopsy or tissue mediated diagnosis. You start the patient directly on ATT. Whenever there is obstruction, surgical relieving of the urinary tract obstruction have to be relieved. For example, the stricture, ureteral damage, bladder or the urethral damage have to be relieved. What are the surgical options possible? Like placing the DG stent, percutaneous nephrostomy tube, draining the bladder diversions have to be taken care of. and the patient have to be started on ATT after checking the patient organism sensitivity and the resistance report. In the previous video only we discussed regarding the ATT. Sorry, that video yet to be uploaded, but in the CMB just before this the topic of ATT was covered. So whatever the TB is, whether it is non-resistant or MDR, XDR, whatever the DR is, XDR, YDR, whatever it is, you have to start the ATT accordingly, which was already discussed in detail. So ATT have a high cure rate. 90% the patient usually responds to the drug with adequate or the appropriate surgical management. So usually after ATT the urine gets cleared out. So this is the image I just kept to show what is the percutaneous nephrostomy tube. Other surgical procedures, as I told, dilatation, reconstruction, diversion. Very rarely the entire kidney, suppose if it is the entirely forms the abscess or entire kidney is destroyed by dystrophic calcification or caseous necrosis, a DTPA scan to detect the EGFR. If it is very low, probably a nephrectomy might be required. Follow-up is very important because there is a up to 6 to 10% of chance of relapse. At least 10 years, every year you can repeat it with culture. Make sure patient nutrition is maintained. Make sure patient is not having any immunocompromised state. If there, that have to be treated first, because this is the manifestation of immunocompromised state. If that is not treated properly, this won't respond. Adequately have to be followed up. Better to attach with the nephrologist or a urologist. Adequately patient have to be followed up, and patient should be told regarding what are the signs of recurrence. So this is a training module on extrapulmonary TB by the Ministry of Health and Family Welfare. As I told, repeat urine microbacterial culture might be required at 2nd month and the 6th month, that is at the end of the treatment. And they have given this flow chart also. Whenever you are having a clinical suspicion, do the urinary examination. Whenever that is negative, look for other DDs. Whenever high clinical suspicion, send for the second attempt to check the urinary testing, then think of starting ATT. But most of the time this flow chart you might not require. What you need to remember, urine culture, urine PCR, urine AOB might be negative mostly because of the incorrect urinary sample processing, or the patient might be submitting it in a very small quantity which should not be, and the entire sample have to be submitted. 3 to 4 times report might be negative, 5th time it might be positive. So that's why you have to keep a constant watch. Mainly clinical correlation with imaging or urine, as I told you. It is not that you go for second attempt then you go for imaging. This won't go like that. If there is a high suspicion of obstructive uropathy, you might directly go for contrast CT. This one spotter I kept for UG question. What it is nothing but the rifampicin induced urine color change. And whenever a patient is on ATT, you can follow it with the urinary color change with rifampicin. So this concludes the Uro TB topic. Thank you. We'll see you in the next video.